Welcome to episode 4 of Primary Care Talks. I'm Dr Chowhan and we're here in St Albans. So I'm here in sunny and leafy St Albans, I should say, after a harrowing journey on the M25 to speak to Dr Steve Laitner, who's a GP here and has a myriad of other roles as well, which I'll let him explain to us shortly. But firstly, Steve, thanks very much for allowing us to do this podcast.
My pleasure.
So Steve, could you tell us a bit about you, your background and what your sort of professional interests are?
Yes, I've been at this practice here, Parkbury House Surgery in St Albans for a long time, since I think it was 1998 I started here, so showing my age. And I've been fortunate enough to join a flexible practice like this as a salaried GP. So I'm here a couple of sessions a week. And I've done a lot of other things the rest of the time, which has given me lots of time to think about different ways of delivering primary care, different ways of delivering better services for patients. My other main career, other than general practice, has been in public health consultant, and then into more clinical leadership and now freelance consulting roles.
Perfect. So thanks, Steve, for setting us up with that. So I guess one of the reasons we're doing these podcasts is try to get messages out there about the new things people are trying, succeeded with, or to be honest, failed with, so that they can learn from it. You and I both know that primary care is under a lot of pressure at the moment, generally because of workload, for whatever reason that might be. And some of the solutions being proposed are around collaboration, around maximising our resources. So really what I'd like to hear about today is some of those things that you've tried and how they're working out or how you think they're going to pan out in the future.
Yes, of course. I think, to be honest, the main problem with NHS thinking at the moment is it tends to be not very nuanced. Fragmented services bad, integrated services, joining up of organisations good. But as we know, the world is more complex than that, and people are more complex than that, or at least some people are. So a lot of the work I'm doing at the moment is a nice mixing up of my individual clinical care background as a GP and my public health background, thinking about populations of people. And I see those two things, those two circles overlapping in a Venn diagram sort of a way. In the middle space, which I call and others call population health management. So that's thinking about how do you manage the different needs of a population, how do you improve the health of a whole population, but also how do you improve the health and improve services for different groups of people with different needs. When we talk about delivering primary care, again, the lack of nuance is people say everybody needs continuity of care and everybody needs integrated care. Whereas actually the truth is not everybody does. And some people who are generally well, people who will be calling us in the surgery this morning who are generally well and get an ear infection or a urine infection or sprain their ankle, or somebody we had this morning been bitten by a dog, they probably don't need a high degree of continuity because they're generally well, but what they need is rapid access to the right service. So what population health management allows you to do is think about the different groups in the population, those that need rapid access without necessarily much continuity, but other groups of the population, such as the frail elderly, who absolutely need very high degrees of continuity, but also very proactive care, not just reacting to their needs at the time. So it's trying to get people into the thinking space of different solutions to different problems, which I don't see quite enough of.
So I completely agree. Anyone who's worked or managed a general practice knows those are the challenges of day-to-day appointments, aren't they, really? It's the flow of trying to manage same-day access with the review appointments and those sorts of things at a very, very practical level.
Yes.
And some of the solutions in the past have been around surgeries working as cooperatives in terms of offering overflow appointments. Some of the responses have been walk-in centres, but none of those have really been joined up together, and they've always been bolt-on additional services, and it's always a little bit loose in terms of who goes where. It's educating the patient as well to say that actually, look, you don't need to see the same GP for your long-term condition, or a GP at all, for your long-term condition care as you do for your dog bite or your earache. And those are the challenges that we're facing. So have you got an approach to that, or some thoughts on how we could tackle that, do you think?
Yeah, and probably something I've sadly spent a lot of my time thinking about, but it's interesting and it's important, and I think things are improving. So I think there's two approaches which are linked. One is population segmentation. So practices or groups of practices, like a primary care home. I work for the NAPC as a regional advisor around the primary care home model. So groups of practices working together, covering a population of 30 to 50,000-ish. The first thing to do is to understand the different groups in your practices. And I think primary care data would be good enough. Ideally, you'd have a linked data set with other providers. But I think we have enough information to know who in our population is generally well, who has long-term conditions, but they're not too complex, and who is complex by nature of having multiple comorbidity, disability, frailty, dementia, those sorts of things. And then the second S is streaming. So what we mustn't do is assume that everybody in a segment or cohort has exactly the same needs, because every individual we know is a unique human being with their own needs and values and preferences that may change from day to day. So what a number of practices are doing, and probably the one that I think is really on the money with this, is a practice in Lewes in Sussex. And what they do is they have the segmentation, but then whenever a patient calls, they have a conversation with a highly trained call handler who will ascertain the person's need at that time and direct them to the most appropriate team. They have a team which I think is called the Complex Care Team, which is a multidisciplinary team of people caring for the people with complex needs, and that's where the integration needs to happen. I developed a 4F model to help people think logically rather than going straight to integrating care for everything, and trying to get away from the NHS's obsession with organisational form. So what I suggest people do is firstly focus. That's the first F. Focus on what are the priority needs in your population that need sorting. So focus on a need. The second F is functions. What are the functions, the care functions, the way we care for people? How do we think of and design those functions that meets the need of the focus? And then thirdly, we might need to think about funding. How does money flow to the services that host those functions to meet the needs of the thing we're focusing on? And then finally, think about what is the new organisational form or vehicle that may be needed to deliver those functions from. So it's a real function before form message that I'm trying to get across.
If I could just take you back to that, the explanations you gave. I'm just interested in trying to bring that together. So, as you know, there's a push at the moment with Forward View to try to get surgeries working more collaboratively, bigger to sizes of 30 to 50,000, and that's where primary care homes aiming its size as well. I completely see that the role of streaming has to become more central within practice, whether that's, the and to some extent we've done it for years with the old-fashioned receptionist doing a little bit of amateur triaging, isn't it? And now that's being ramped up with care navigation or some form of an official streaming function. So how important do you think it is for us to be working in sizes of 30 to 50,000 to be able to succeed in doing things like streaming or with the model that you said is being used down in Sussex?
Yeah. So I think primary care home and primary care networks, neighbourhoods, whatever they're called, clusters, I think people have unusually agreed on a size. It's flexible, sort of 30 to 50,000-ish, but a size of a natural community and a size where people working in that community in terms of health and care can be of the size where people would know each other to be able to call them and work as a team. So I think the size is right, but there's never one size for everything. So some things will be better done by an individual practice, and some things will need a function at a bigger level. And a hospital would be a good example for that, for highly specialist, particularly inpatient care. But let me give you two examples where I think the segmentation and the streaming come together needing some functions that probably each practice isn't quite big enough to deliver. So one is, as you mentioned, Hassan, call handling and care navigation, which I think is quite a skill. And I think that's about directing a patient when they've not got a new clinical concern, but they need some help with navigating the health and care sector. And what we want to make sure is those people aren't on the duty doctor triage list, but they're sorted through a highly skilled and trained receptionist, or call handler, probably a better term, who is embedded in and knows the local community. And I think that can work really well. However, if it's a new clinical problem, that does need to get through to a clinician. And I think GPs are really good at clinical triage and managing risk, clinical triage on the phone. So I could see, and I was speaking about this with GP colleagues in Hertsmere yesterday, I could see a function at a primary care home or cluster level, 30 to 50,000 level, where the call handling and clinical triage is done on behalf of a few practices. And then when people need to be seen, and I think anybody should have a phone call or a digital exchange before they're seen to get them to the right person and to manage on the phone if appropriate, that could be done in the individual practices or in a hub. The second thing where I think individual practices don't have the capabilities around people with complex needs. So if you take a frail older person with dementia, diabetes, COPD, perhaps having had a stroke, depression, social isolation, many of those problems are best met by other people than a GP. And people with those sort of needs are likely to need a multidisciplinary team working together to manage the different needs as a highly functioning team. And I don't think individual practices have all the capability to do that. So I see those two functions, multidisciplinary care for people with complex needs and the call handling, streaming and clinical triage, being two examples of a function that could well sit at the cluster or primary care home level.
So I think one of the things you've identified there, Steve, thanks very much for that explanation, by the way, but one of the key things you've picked up on is that I don't think that can just be done by general practice or by primary care. I think there's a large social care function, voluntary services, community provider, whoever there is in the community of where you're at, to try to get involved. And so I guess the other thing I wanted to talk to you about was, I know in the past you've talked about accountable care providers and led on that, and you do some work with STPs and ICSs as well. So do you think that's the key to getting this right going forwards?
I think it is, so long as we start with the focus on the functions first. And it's quite easy to slip into too early thinking about the organisational form. I absolutely agree with you, and I don't think I made this clear enough in my explanation. The multidisciplinary team looking after people with complex needs would include many people who aren't currently in primary care. They're not part of the primary care workforce. It might be a social worker, might be somebody from the Alzheimer's Society providing carer support. It might be a trained peer volunteer to have the initial care planning conversation. So it really starts with the person's own values and preferences, not with what a doctor says they need in their care plan. So with the work of the NAPC in primary care home, it's not just about practices working together, it's about practices working with the local community trust, with the voluntary sector organisations, with the whatever community assets there are. So the park run is part of a primary care home. The local Alzheimer's Society is guided walks, all the things that happen in the community to keep people healthy and linked into society are part of that, or should be part of that cluster.
I agree, because as you know, working in primary care, you can't be doing this by yourself. You need help. We need help. And that's got to come through our community assets, through our stakeholders, through everyone out there, even actually our patients themselves. Now, I know you're interested in digital technology and platforms. So what do you think the role for technology is in some of this, or do you think it's separate to this?
So I think technology is absolutely critical, but I don't think we should start with the whizzy stuff. I think we should start with Alexander Graham Bell's invention in the 1800s, which is the telephone. And even now, many practices aren't providing telephone access to their patients for urgent access and for follow-up, and I think they should. And I think the NHS wastes a huge amount of money, as you said earlier, setting up walk-in clinics and urgent care centres which don't have that digital and telephone front end. So I personally think we should pretty much never see anybody unless we've assessed them remotely first, because otherwise we can't know how best to help them. That doesn't mean we should turn away people who do walk in, but a assessment could be through a text exchange, may in the future be through smart artificial intelligence. It should be digital first, telephone second, and then face-to-face after that when required.
You're listening to Primary Care Talks with Dr. Hassan Chowhan. Interesting to think that I think we're slowly getting there with the likes of 111 now having to use the digital platform once it starts to gain momentum. And also this week we've had Helen Stokes-Lampard commenting on the Babylon app, which has taken London by storm, I gather. Fortunately over in Colchester it's quite foreign to us, that sort of concept, but you're probably close enough to London to maybe feel some of that effect, I don't know. So Babylon is a service that's I suppose best thought of as a virtual general practice, which doesn't necessarily have a presence as a traditional general practice, but is operated through a remote smartphone app where you can contact the GP, and then you can have you can have a video or a telephone conversation with a GP within 2 hours is the marketed time. And if needed, you can have an appointment the following day, and you're able to register with them as you would with a normal practice. You know, that sort of technology of using apps and video calling is something that's growing in terms of need for patients, largely the younger cohort. But I think we're going to see technology play a greater role in primary care and delivering healthcare, whether that's at the point of triage assessment or some sort of a streaming function before they hit our door, or whether it's for longer term care with the applications like MyCOPD or something like that, which allows self-care to really take on the next digital step. MyCOPD is a software platform which have lots of advice for patients, so there are access to videos and guides on doing pulmonary rehabilitation, which is exercises for your COPD, but also has a clinician platform where you can actually track progress of your patients. So if your patients are going online and recording how they're feeling today in terms of their symptoms, actually on a geographical map you can see via smiley faces where the good ones are, where the bad ones are, which allows you to focus in as a snapshot to see actually I see that area's got a lot of my patients suffering, and it can start to link into, is that related to pollen count, pollution, those sorts of things. So Steve, I guess the next question that is worth asking is you've clearly thought about a lot of changes, hopefully implemented some of them within this practice and within your other roles. There are always barriers. What do you think the barriers are to us at the moment in terms of making these changes for the better delivery of healthcare for our patients?
So I think talking about technology and even thinking about the simple phone is a great example of the barriers. So although we haven't had experience with Babylon locally, due to the luxury of having lots of time outside of general practice to think about these things and the headspace of my previous roles with primary care trusts and health authorities, I helped the practice introduce telephone triage here more than 10 years ago. And we find that has transformed our practice for the better. Now, it's not always an easy journey, especially to begin with, and different ways of practicing take some getting used to for both clinicians and patients. But I think the sorts of barriers are exemplified by the things I've come across trying to persuade and help practices to adopt telephone access and then perhaps digital access of the type you've spoken about. There's the sorts of things I hear from clinicians which I think are wrong. One is the demand for healthcare is infinite. It's not infinite. Health and healthcare isn't the only thing that people are bothered about in their lives. So people only have a certain desire to seek medical attention and medical help. So I think some of the concern is that if we open up access through telephone or smartphones or other means, we will be swamped with demand. That's not what we've found. And we haven't found that over the years the demand has gone up. It's highly predictable. So I will know on a Tuesday morning when I'm doing triage here, we've got a practice population of over 20,000. We'll have about 120 calls between a number of us. So it is highly predictable, the demand, and it's stable. Obviously, if there was unmet need, then the numbers might increase from what you found before. But we mustn't use delay or lack of access as a means of managing demand. We will then deny people care who need it. And I still get clinicians saying, but I have to see the patient every time. I had one junior GP not long ago tell me that he had to see every patient with a sore throat and he couldn't possibly assess a sore throat over the phone. There is no way that everybody with a sore throat wants to see us, and there's no way we have the capacity to see everybody, without a shadow of a doubt, unnecessary to see everybody with a sore throat, but through a simple telephone call you can ascertain those who you do need to see. The other thing I hear is, but everybody wants to see me, and that's not true either. People have got other important things to do in their lives, and what people often want is the symptom or concern, and it is often a concern and just a need for information and reassurance. As we know as GPs, they want that quickly. They want to get on with their life, with their work, with their family, with their recreation. So I think, to be honest, the medical profession can be rather conservative. We can be a bit precious to think we're the most important thing in people's lives, and we can be not open to the sort of innovation and the technology and the ways of managing our lives that we do in the rest of our lives. I think overall, my last point on this is that what would help us is to have a much more customer type approach in our thinking. So rather than blaming patients or denigrating patients for wanting to seek help or for going to the wrong place, let's redesign the service based on their needs and preferences and work with patients and patient leaders and people from the community. And I think if we do that, we will find actually demand goes down, not up.
I suppose what I'd also like to hear about is so I completely understand that that's a challenge, isn't it? And I think many of us who like to play around with innovation and try different things within practice face those challenges from our colleagues and peers, don't we? I mean, I work 6 sessions, you do 2 sessions. I think you always face that hierarchy in general practice, don't you? That you don't know what it's like because I work 9 sessions and you're not really in it long enough to know. So I guess really my question was you've obviously made a lot of change here in this practice, and you said there was a junior GP who was struggling with the sore throat concept, and so have you worked over those? Have you got to a point now where actually many of your colleagues now here are working with you on some of these things, or is it still a bit of a fight?
It's not a fight here anymore about clinical triage, and it probably took a year or 2 for people to become comfortable with it, but I don't think any of the GPs, even the ones who were sceptical at the beginning, would go back to the old system. You know, the work can be hard, but we're in control. We know what's likely to come through the door each day, and we're managing it, and we've increased our numbers of minor illness nurses. We have increased our practice because people like that good access. I suppose the 2 things I've learned through life and trying to implement change, one I learned in a public health leadership course, but they spoke about leading through others. So what I did in this practice was I partnered up with one of the partners who was the full-time GP partner you mentioned, and I was sort of leading through him but in the background. And there was a great quote I heard the other day from Sir Bruce Keogh in a sort of post-retirement from his medical director role talk he was giving the other day. And I think it was a former US president who said, it's amazing how much you can achieve in life if you don't mind who gets the credit for it.
A great thought, and I think that is key. I sincerely believe that as well. That actually, a lot of the time, people get more caught up with taking credit for their successes, and I also think if you focus on that too much, you become too aware of the risk of failure, and that sometimes stifles change and innovation as well. I think, Steve, you've probably already answered my next question, but really I was going to ask you about the benefit for patients. You said your list is growing, so I'm assuming the changes you've put in place here with regards to triage and the structure within the practice has meant your list is growing and your patients are satisfied, dare I say?
Yeah, no, I think they are satisfied, to be honest. And I love working on triage because the patients are happy. We would never deny them an appointment if after the end of a call we think clinically they don't need to be seen, but they're not reassured enough from the phone call, we'll see them. And I still get great pleasure of saying to a patient, well, we should probably see you, and we ask them, when would you like to come in? Who would you like to see? And we can book a double or triple appointment if they've got a number of concerns. So it's a service that we're able to adapt much more to individual needs. I overheard our triage doctor today saying to a patient, if you can come in 10 minutes, we can see you straight away. So it's fantastic to be giving that level of access. And it's also fantastic when somebody calls with a concern, and within a couple of minutes, they're reassured without any need for anything else. What I think, in terms of patients, what I think we don't use enough of is patients themselves in helping us to redesign the services. And in choosing the right patients to help us, we have to be just as selective as we would be choosing a clinical leader. But if we get the right patients, and I was with one in a group yesterday, and I thought, to be honest, the patient leader outclassed all of the GPs, and myself included, in the way he was explaining things, in his positive approach to things. And I think, to be honest, even if we just pick those two priorities of same-day access for people who are generally well or well-managed long-term conditions who have an acute concern as one, and as the second, the care of people with multiple comorbidities and complex needs, that would be two big chunks. And if we got those two bits right, I think we'd be away. And I think primary care has the solution to 90% or 95% even of the demand in those two areas, if not more.
And I couldn't agree more. I might amend the statement a bit more. And I think actually primary care probably has the key facilitating role, I think, to those solutions. And I'm sure you'll agree, for the reasons you've mentioned, that we need to get ourselves in a place where we can separate the two or identify those cohorts. But then it's really about who else we can bring in to help us. Now, some practices are doing this out of necessity. They're looking at external agents to try to come into the practice and work with them. Some of them doing it proactively. But I think ultimately 5 years from now, or maybe even sooner than that, primary care as the practice is going to start to look very different in its function, and actually with what comprises primary care in terms of the multidisciplinary team. And hopefully, as you say, we can bring patients on board with that as well to help shape and design the service. I think one of the biggest shames that we have at the moment is many places struggle to get patients to participate and get involved. And I think some of that's just really about how you set it up. So if you have a meeting on a Wednesday afternoon at 1, you're going to get the same sort of people. If you start to use social media, start to use evenings, start to use other forums to bring patients on board, then you're more likely to get that input, because really the service we're trying to develop 10, 15 years from now really isn't going to be shaped by the people that have their health needs now. It's going to be the people that don't have their health needs now, and their health needs for those people, I'm sure, is going to be very different going forwards. But we shall see. So Steve, thanks very much for taking the time to talk to me. It's been a real pleasure hearing some of your ideas. I'm really excited to see some of these things come to fruition. The 4Fs is a great one I've not heard before. It's been great to come to the practice. Thanks for having us. One final thing really is that sometimes people out there might say, well, how do I get in touch with Dr. Laitner to ask him questions? Is it possible for us to maybe tout your email address or a contact that we can use?
That would be fine, and thank you very much. I've really enjoyed our chat too. It's been great, and I'm happy for you to add my Twitter handle and my email to the details of the podcast. Would be fine.
Thanks very much.
Thank you very much.
This has been a really useful conversation with Dr. Laitner to hear some of his thoughts on population health management. As he has said, though, I think the challenge here is going to be trying to get general practice and primary care to think in a different way. They're going to need help, we're going to need help, and that's got to come through the outside parties, outside agencies, and to use his term, the community assets. So through using our community assets and our patients, we should be in a better position to design a service that not only is better for patient care, but should be more sustainable for the future, fitting in with the changes that are likely heading our way. Thank you very much for listening. I hope you're finding these podcasts useful, and I look forward to speaking to you next time on Primary Care Talks. Join us on our next podcast when I'll be talking to Caroline Prentice, a practice manager in Bedford, about the use of a live core for screening atrial fibrillation and the successes they've had in their practice.
A quick reminder, if you are planning local changes or initiatives, always involve NHS England to make sure your plans fit within the national guidelines.